Hi, everyone. Can people please take their seats and we'll get started? All right. Hello, everyone. Welcome. I'm Senator Cece Marr, and I welcome you to this month's TCB meeting, Children's Behavioral Health Policy and Planning Committee. Before we get started, and I want to thank everyone who came today on this miserable day, and thank everyone who's on Zoom, because I know a number of people are on Zoom. But before we get started, I just want to recognize that Representative Tammy Exum is not here today with us. And we know how deeply important this topic is to her and how dedicated she is to this committee. And we look forward to her joining us when she's ready, whenever that may be. So thank you all for being here. I am excited that we're back again after having missed last month. And I really look very much forward to hearing what everyone has to say about how we are caring for our children in Connecticut.
Thank you, Senator Marr. And Claudia Gualtieri, just want to also add my words of welcome to this meeting. It's been a little while since we gathered, but we have a fantastic set of presentations today, and look forward to continuing the important work that we have to do, especially leading into next session, and also echoing deep, heartfelt sympathy for Representative Exum and her family right now, but knowing that she gave us the passion and energy to fill in the interim, and we're going to chug away until she's ready to rejoin us with that North Star that she gave us at the first meeting. So hopefully we can move on through to the next part of the agenda.
Okay, thank you, everybody. Erica Nowakowski, the Executive Director for the Tau Youth Justice Institute. Just a couple of housekeeping. For those of you that are here physically and may have a laptop and are on Zoom, if you can make sure to mute yourself, because there sometimes can create an echo. And then secondly, for those that are virtually on, raise your hand. We will be continuing to monitor the screen and making sure that we get to you. If we do not get to you, please know that it is not that we are ignoring you. We will try. It may just mean that, depending on the time or what the lively conversation is happening, you may just be put on hold just a little bit, but we will try to get to you. Another thing, you'll get to hear some very lively presentation today, just like we did in September. What we are hoping, because we do have such a short period of time together in these very complex conversations and so forth, and very comprehensive conversations, is that we ask that everybody reserve your questions. Wait till the end of the presentation, write down your questions, put it on chat. We will be collecting those. We will get to you, but I think it helps the flow of the presentation if we just hold our questions until the end of the presentation. This meeting is being recorded and it is being viewed on CTN. The next slide, please. Okay, so a couple of things just for housekeeping. Just for the acceptance of the minutes.
Yep. So everyone should have received in their packet for today's meeting our September meeting minutes. I trust that the committee members have had a chance to review, and I'll entertain a motion now to approve of the September minutes. Do I have such motion? I have a motion. Do I have a second? Second by Representative Walker. Thank you very much. Any discussion or edits needed to the September meeting minutes?
Here.
Yes, I hear someone virtually, I believe.
Senator Lester.
Senator. Yes.
Mr. Chair, I would like to abstain.
All right. So noted. We could take a verbal vote, I think, a voice vote on this. If all those in favor of approving the minutes as submitted, the September meeting minutes, please signal by saying aye. Aye.
Aye. Aye.
Aye.
Any opposed? And I'll note the one abstention from Senator Lesser. Thank you.
Okay, thank you, everybody. And for today's November meeting, November meeting, we will, you'll get to hear a brief update from us at the Tau Youth Justice Institute. It's a continuation from the conversation that we started back in September about the operationalization of the work. We'll give you all an update on that, as I know we have received multiple emails from many key stakeholders asking for an update. So we'll give an update on that. And then we have continuing the conversation, if you all may remember, in September, we had a presentation from the UCCs. Part of the flow of presentations that will come to you in these next several months is also just continuing what the system looks like for children's behavioral health, from the most complex, intensive services to then the preventative side of the services. So today's presentation will be a presentation on outpatient services, and we have a great slate of presenters coming to you to provide that presentation and be available to answer questions that you may have. So as noted, the September meeting, the Tau Youth Justice presented sort of our proposal for how we would like to operationalize your work, our structure, and we'll dive into that a little bit more today to give you an update. We released a survey to get your feedback and input about how our recommendation for operationalizing the work, and we have compiled that feedback. Another survey that went into that was asking for volunteers to raise their hand and to be co-chairs or to be possibly appointed as co-chairs of the work groups. And we did receive a very good response to that, and we'll provide you an update to that as well. So thank you all for responding to the 2 surveys that went out. And as I mentioned earlier, there was a presentation about the Urgent Care Crisis Center. It was a very engaging conversation. I think we ended up staying past the time because there was a lot of good questions. And with that, know that because in the beginning of a process like this, there tends to be a lot of information gathering, right? A lot of knowledge-based, gaining some knowledge about the systems itself. So one of the thoughts that we had is that for the next few months, we may urge and request that the meetings be extended, because instead of us, it's just not 90 minutes is not enough. And so, for example, for today, we extended it from 2 to 4 because it is very good dialogue. It is a lot of really good information. There's been a lot of time that has been put in place to prepare these presentations and all of this information for you. And so I think that allowing the time for you all to engage in those conversations and ask the questions is appropriate. So we will be asking to extend the time. Now, some of you have reached out to us and also asked that if we're extending the time, could we maybe modify the start of the meeting, maybe make it a little bit earlier so we're not ending later in the day. All of those suggestions we are gathering, and we will bring that forward to the chairs for consideration. So please know that we did get, some of you reached out, we did get your emails, we got your questions around that, and we will be addressing that soon. Okay. So here is quickly an update to you about the operationalization, of our work, and I'm going to ask Ash to give that update.
Thank you, Erica. So last meeting we did, as Erica just mentioned, gave you all a little homework to fill up the survey and get back to us. Thank you so much for filling up those surveys. Now here we present the data that we've received from all of you. So we have amended the organizational chart. Some of the common feedback that we've received from everyone is to have a separate finance group and a separate data sharing group. So as you see under the system infrastructure work group, you would see that as highlighted. Something that we also discussed in the last meeting is that finance should be embedded in each of the work group. So that would also be our focus in each and every work group. Finance would be a component where it will be discussed. The other thing that people have recommended is services, school-based work groups should have individual work groups and shouldn't come under any other work group. So we've given each work groups designated for school-based, for services, and for prevention. So the homework that you all did, there were many people who signed up to become the co-chair candidates for the work groups. So right now what you see is 17 members have said yes, that they would want to become the co-chairs. The numbers here are a bit tweaked. So when finance and data would come as a work group, few of those co-chairs would become the co-chairs of finance and data sharing. So we've got 4 members for system infrastructure, 5 for services, 5 for prevention, 6 for school-based, and 1 for strategic work plan. This is the number of people who have signed up for the work group. So it was given to the committee members as well as to all other members who were interested to become a member of the work group. So in total, we've got 81 responses, and some common themes that we found from the recommendations are listed over here. So some of the common themes were that the TCB should focus more on services, payment, and system reform. Other thing that was highlighted was the past work shouldn't be duplicated when we look at the work going forward for. All the common themes that you see right up there are the themes that we found in common. And also in the email that we sent out to you yesterday, there is like a 5-pager document which has detailed recommendation and comments that was compiled through these survey. And now how would our timeline look like for the co-chairs candidates to become the co-chairs, for the work groups to convene? So early November, many of you who have signed up to become a co-chair would have received our emails asking for your resumes, and we've collected a lot of resumes by now. At this point, we are trying to work out what dates fit well for the tri-chairs and the co-chairs to come together for the interview process. Once that is finalized, we would send out invites for the work groups so that we can start convening those work groups. If you see in the late November, there is few sentences that are highlighted. So the idea is, and Erica would speak more about the legislative recommendations that's coming up in the next slides. So once we discuss about the legislative recommendations, we would see which work group should convene first, what are the priority areas, and which work group should get started first. So those work group would get kick-started late in November, and other work group would get convened, and we would give them the work plan from the recommendations that we've collected from all of you. And in the month of December, we would like to give those draft legislative recommendations to the committee. Over to you, Erica. Thank you.
Thank you. And so on this page here, what we're trying to do is there's a lot to be done, as we had mentioned before, and through the legislation that formed this committee, there's been a lot that was identified there, a lot of different due dates. And so we are trying to prioritize the sort of the work that you are all been charged with. And so between now, and this is a tight timeline, by the way, but between now and about March, right, we have identified sort of 4 areas. And one of those specific tasks is, and then you'll hear more about from our Karen Snyder, is regarding statewide listening sessions. Many of you have asked, you know, can we go out? Can we hear from the clients, the children, the families? Can we hear from them as to what are the barriers, what are the challenges, and what recommendations that they would have? And so those statewide listening sessions are in the process of being coordinated, and we have received quite a bit of organizations who have offered to be a hosting site for some of these statewide listening sessions. So we're going to cover the New London area, the New Haven area, the Bridgeport area. They're going to be all across the state in different parts at different times. When we get to that portion of the presentation by Karen, you'll hear a little bit more details as to how we plan to engage different individuals and what the process is going to look like for registration and so forth. The other area that we heard from you all too is that this committee is hungry for legislative action. And so there may be many things you all may want to do for 2024, but we also need to prioritize some of those things and set some realistic legislative actions, recommendations. So we do plan to work with our partner UConn to engage you and many of the stakeholders in some development of legislative recommendations. Now, through those that process, we may come up with 100 recommendations, but that doesn't mean that those would be what comes forward to you. We will still keep in mind all of those recommendations that maybe may not go forward in 2024 and use them as a platform for the work moving forward. And those other recommendations would maybe be assigned to specific work groups to dive into further, identify what the problem is, identify what the data says. Are there any best practices or what does the research say around some of this particular area of concern? And then what are some of those strategies that we would, want to bring forward? And what is the potential impact to the system, right? Whether it be legislatively, whether it be financially, whether it be, what are all those levels of impact? It's important to have that understanding. And that's what we would spend a lot of time in 24, really diving into that to make sure that we bring forward a set of recommendations in 25 that are not, that have been researched, that have been, that we have the data to show justification why we want to reform the system or make a legislative change in that direction. The next area of priority between now and March is a level setting training. We have heard from many of you that you'd like to, come to have a little bit more understanding when the acronyms, the alphabet soups are being used, and or what does financing look like in this world of children's behavioral health. It's some of the presentations that you've been getting about the urgent cares and the outpatient and then in-home services. Well, what is that? What does it sound like? Who are the providers? How many kids are we talking about? So those are some of the areas of this level setting training, this 1-day level setting training that we are looking to partner with some of the members of this committee to develop and bring to you and host, preferably before the legislative session begins. And so you would be receiving an invitation to that. So stay tuned for more information about that. And then the last thing, which is actually, I consider it to be maybe one of the things that will help us as you all evolve in your committee, is an orientation manual. Because it is important to have some historical content, but it's also important to understand what you all are, what your project plan is, your steps, what is the legislative recommendations when Erica says legislative recommendations for this committee, what does that look like, sound like, what's the process around that? So that orientation manual will spell out some of those details that you can use at any time to reference. And then whenever we have a new member coming on board, we at the Tau Youth Justice Institute would provide a brief, tutorial around the committee, the history, where you are today, and what you plan to achieve. Your orientation manual also will have what we hope to accomplish by July of 2024 is your strategic plan. Which we will have quite a bit of work to do in the next several months around that. Okay. I'm going to invite Karen now to speak on the listening sessions.
Sorry, I'll start again. Sometimes it's important to take action, but a lot of times it's really important to listen before you decide what actions you're going to take. And so we've designed a pretty ambitious, but I'm very excited about it, plan to move around the state and to engage with, as you see on the diagram here, lots of different constituencies.
Karen, I'm sorry, would you introduce yourself, please?
Oh, okay. I'm Karen Snyder. I live in Connecticut for several years before I came to work with Erica. I was working in Massachusetts, helping to implement what they called their Rosie D initiative, because it was, it started, well, it didn't start. It got expanded because of a lawsuit, a federal lawsuit, a Medicaid lawsuit. And through that process, the entire system and service system and quality management system, the data system, everything over that period of many years was redesigned and implemented so that we had a behavioral health system you could see and touch and know what it was supposed to do and what it was doing. And we had a pretty major evaluation system that not only included data and diagrams, but one of the key pieces that I played was I developed a protocol in which we went and randomly selected families who were engaged in being served by this variety of systems of care, and evaluated their care, their outcomes, their satisfaction, really got to go live with families over a period of 3 years. I went to their homes. They came. I invited everybody to participate. The team that I had that helped me do this consisted of legislative people, consisted of state agency people, parents, just everyone I could think of from the community. And we came together, formed a team, trained together, used the same protocol, and really took a look at what is the real work we're doing. You got down to the nitty gritty. I learned my way around all of Massachusetts. There were towns I never heard of. I went to visit. So here, one of the things that I'm going to be involved in are these listening sessions, which will give all of us a chance, and we'll be sharing all of this with you, because we'll be listening to these different constituencies you see on the slide about their experience with, their impressions of, their recommendations around how to ensure that the mental health, behavioral health system for kids and families in Connecticut, what it's like now, what their vision of how it should be, and what you believe needs to be done to get us from where we are to where you think a good system is. There's a lot of good work going on in Connecticut, because just in this brief amount of time, I've had a great chance to talk with many people, and there's a lot to feel proud of here. But it's important to be able to outline that and speak to it and highlight it and continue to improve it and have a roadmap for that going forward. So if you want to switch over to the next slide, the listening sessions, there's actually, we've developed a little, what you're seeing there, a statewide listening session roadmap. So between now and April, we'll be going around meeting with all the varied constituencies, parents and youth that are old enough to speak to us and have opinions and those kind of things, are key to me in terms of hearing about this. It's really about the kids and the family. We're the doers, we're the workers, we're the ones that need to feel accountable to them for what we decide and what we do. So much of this is going to be focused that way, but there will be all different constituencies we're talking to, so that by April we'll be have a report. We'll be summarizing what we did, where we went, what we heard, and put it into a report, and that'll be available to all of you to see the system through our eyes of all these listening sessions. So, and if you want to come to any of the listening sessions, if you'd like to join in, feel free to contact Erica or me or anyone on her team, and we can brief you ahead of time. We can help you organize your transportation. You would be most welcome. It would be very exciting to have people see and hear directly from the kids and families that are the receivers of the hard work in Connecticut. So thank you.
And on that note, the first listening session is actually been scheduled for November 15th. And that particular region will be the New Haven region. And we're working with some of the providers there to host. And as if you were to go to the slide prior, we highlighted youth and parents. We decided to start with them first. We are going to get to everybody else around that circle, but we're going to start with youth and parents first. And as Karen mentioned, transportation, we are making sure that a couple things, that the listening sessions are in the afternoon, so it doesn't interrupt, or early evening doesn't interrupt with the child's education and or parents' work. And we are going to make sure to provide transportation. So in case any parent or youth is experiencing transportation issues, we will address those barriers. So very excited. I also heard food is very much something that we will be very much making sure we have available for them. So please join us. We will shortly, my team, we're just in the process of finalizing the flyer and the announcement for that. You will see all the dates across between now and March, and then the locations that we are scheduled to be at, and then how you can register for that specific location or come to any of the locations that you work for your schedule. Okay. And the next item here to discuss is, you've heard me mentioned about the committee's hungry for some legislative action in 2024. And so this is one of those items that would be in an orientation manual. How, this is what we propose. Now, this is a draft. It can be modified, but this is our proposal for how we would organize this committee for some putting together some legislative recommendations that would be brought forward at the beginning of the year. We still have to determine, now this is, I said January on here in the sense of a time when this committee would vote for a set of recommendations, but that could be modified. We may want to say December, or I'm not this year, but I'm talking about, moving forward December, because we may want to do it before the legislative session, so some thoughts, food for thought. But the process for the recommendations is that it typically is homegrown from the work groups. The work groups identify based off of your work plan or your strategic plan, really, those set of priorities. And then the work group is where the conversation is taking place about a specific area that they want to target, that they want to bring forward to this committee to vote on and so get your support. But before that committee or that work group can do that, they would need to do, as I mentioned earlier, review the data. What is the best practices, or what does the research say around it? And then build some consensus around a set of recommendations that would come forward to you all for consideration and for your own feedback. Okay, so that is the circle that you see here is on a typical year. If we had that full amount of time, this is what my proposal would be moving forward. For 2024, we really just have less than 2 months to formulate a set of recommendations. And so one of the things that I challenge you all is that we will accept all your feedback, but I challenge you all to really prioritize which specific recommendation. And, because we don't want to set ourselves up to fail, right? So we want to make sure that we prioritize. It doesn't mean that other recommendations can't come forward, but if this committee wants to champion something and bring something forward, we want to make sure we have the data, we have the support, and that we can bring, that you all are successful in this process. And our job is to help you become successful in that process. So that's going to be your challenge, is to prioritize and narrow, at least for this year, narrow the number of recommendations you bring forward. Okay. Rep Walker, you are perfect timing because we are open to questions now.
I'm sorry.
Thank you. Okay.
Yes, Representative Walker.
I just want to clarify something. On here you have February to June, and you say legislative session and public hearings. This is a short session.
Yeah.
So that should be February to
May.
really April, maybe end of March, April, because well, our probes and finance is the last, and we have our JF deadlines are probably the first week of April.
Okay.
So
Okay.
that means everything's sealed in a package.
Perfect. We'll make
Okay.
that adjustment.
So that's why I think it's important that everybody knows it's really a couple of weeks.
Yeah.
Okay.
The short session. And so moving forward, we'll delineate that in the graph as well, in the chart about the long session versus the short session. We'll make sure to that. Yes. Oh,
Sorry, let me just take one moment to pause and give credit to Tao, because I think there were 3 big themes that I heard from the initial meeting. One, that we all thought it was very important that finance was a shared conversation owned by all the work groups. And so to intentionally embed that in each of the work groups, I think is the perfect way to have those side-by-side conversations, the services, the gaps, the programmatic with the financing, and how we're going to make sure to deliver on that. So I appreciate that. Secondly, I think that there was a real feedback from the council of trying to make the listening sessions most conducive for the populations we need to hear from. Like, we're building a system around children and families and parents, and I appreciate the timing and the accommodations that you all thought through to make these effective. And then the third, I think, is all of us come from different perspectives in the broad spectrum of behavioral health, and the level setting so that we can have an operating set of facts so that we're all meaningfully contributing and having a rich back and forth is so important. And so I would give credit for you guys for the orientation packets, the timelines, the breaking down of the alphabet soup. So I just wanted to pause and give you credit before we keep moving on.
Thank
Uh,
you.
Go ahead and I'll recognize you.
Hi, I'm Tammy Benegay from DDS. For the listening tours, how are families being identified? Is it it's like we can invite families, or are you identifying certain families, or are those things that we're getting the invitation and we can invite families as well?
That is good. Thank you. Thank you for that very important question. So it's going to be a hybrid. So there were a couple organizations across the state that volunteered to host us. So we needed a site, right? We needed a location to be able to do this. And so those specific organizations work with children and families. And so we are asking them to help us, to invite the youth and the children, the youth and the parents. But we are also opening it up for the larger community. So within the larger community of New Haven, and so there will be a registration process as well. So spreading the word that we're not just looking for those children and families that are within that provider network, but in the community. And then we are asking you as well. So you will receive the notification and the announcement, and we're asking you to share it out because the more we can hear from the voices that are impacted, the more comprehensive and well thought out content you will get.
I'm just thinking that a lot of our children aren't connected to community providers, and they have one provider that goes to their home that sees them. So they're not going to be looped in to a community provider. But if we get the invitation and have an open invitation to send it along to our families, then that would be very helpful. So I appreciate that. Thank you so much.
Yeah. And just to clarify, definitely the listening sessions will be open for. Other questions regarding the operationalization of the work, thoughts? Feel free. This is still in draft, and so we are, continuing to make modifications like we will, and as we are building the orientation manual, more of these details will be spelled out. We love details, so send us your feedback, send us your thoughts. We will compile it and circle back with you if we have any questions. All right, so our portion is done. I'm going to give the floor now to our great presenters. And first I want to say, one of the things that we strive to do is that we want to be mindful and planful about who's coming forward to you. And in order to ensure a successful presentation, we spend quite a bit of time meeting with the presenters, not only who they are, but also what content, what materials, putting all of that together with multiple meetings that were held. And so I just want to say thank you to not only the UCCs that presented in September, because they did an amazing job and working collaboratively with us to prepare for that meeting, but also today's presentation with the outpatient providers that you'll hear from. They have been amazing. They have been very much took the time. I think you're going to have a lot of really good information today. So for today's presentation, when we say outpatient, there will be a definition that you'll hear about. I also want to be clear that in-home services is part of that outpatient network, but for today's purposes, we won't be diving into that. That will come to you later, because both those conversations, whether it be a traditional outpatient service or like an in-home service, is very robust information. And we just don't have the time to have that very comprehensive conversation. So we will preserve the in-home outpatient services for a following meeting. So with that, I'd like to bring our presenters forward. Oh, sorry, and yeah, with parents.
Good afternoon. My name is Edith Boyle, and I am an LCSW and the president and CEO of LifeBridge Community Services in Bridgeport. For the past few years, patient-centered care has been an intense focus of healthcare leaders, especially when trying to provide excellent care. We continue to rethink care in the way that amplifies the voice of the individuals utilizing services. Both clients and caregivers' voice add different perspectives to everything that goes on in healthcare and can point out gaps. With that, Charlotte, a resident of Bridgeport, is here with me today to share her personal experience accessing and utilizing behavioral health services for her daughter. I want to thank Charlotte for her willingness to join us today and for all she's done and continues to do to support and advocate for her daughter.
Good afternoon. I'm Charlotte. I'm from Bridgeport, as she says. I'm also Jamaican, so I'm a strong believer of helping my kid in as much as I can. I heard about Life Bridge because I had an incident at school with her. She's been struggling with mental health because she has heart and lung disease, and she takes a lot of medications. She's went to public school. She got into a fight. Nothing was done. She's been bullied every day. Nothing is being done at public school. They jumped her, beat her up, put it all over the internet. So she's been having a lot of difficulty with that. I moved her to Great Oaks Public Charter School, and it got worse. She told me she didn't want to be here anymore. So I had to call mobile crisis. They call mobile crisis at the school. Mobile crisis, reach out to social workers. Nobody called me. They told me I had to find a way because it could take 3 weeks before somebody reached out to me. Her dad found LifeBridge on his own, and he called, and we got an appointment as soon as it was available. And it's heartbreaking to know that school are not helping. It's not. I moved her from one school to the next, and it's still heartbreaking. She's a very special daughter to me, and I fought for her to be here. I fought. They told me she wouldn't live to see one, and I fought. And to know that she's going through so much pain in school because of bullying, and she don't want to be here anymore, it really hurts my heart. And also parents like me need help. I can't do it alone. I asked for help. They told me I needed to be in a waiting list to be talked to someone because I struggle with the fact to know that my kid is going through that. Her sister struggled because we see it at home. We see it in the school. And it's not fair. And my recommendation is to help us as parents, give us the tool so we could help our kids, because it's not easy to hear your kids say, she don't want to be here anymore. So it's pretty much sums everything that I've been going through with her. And I want to thank you guys for all the help that you've been putting out. You know, it's a community, and we all need to come together and try to help these kids. And nobody would know what we're going through because we as parents hold it in to be strong for these kids. But I just want to thank Tanya at LifeBridge because she's amazing, and it's been helping her. It's been better since she been seeing Miss Tanya. I see her smile again. You know, sometimes you don't even know how to talk to her because you don't know what to say. So I just want to I try to make sure I'm there every single Tuesday because she could express her feelings to Miss Tanya, but she can't express to me. And then we get to move forward with whatever treatment she needs. So I just want to thank LifeBridge and everybody that's in this program. Thank you, guys.
Thank you, Charlotte. I think on behalf of everyone, we appreciate you taking the time. And I'm sure at the end, there may be some questions for you.
Thank you, Charlotte. And we will definitely make sure to engage you in some questions a little bit later. Now I want to give the floor to Jason from CHDI.
All right, thank you, Erica, and also want to thank you, Charlotte, for sharing your story. It's very powerful, and we appreciate having you here. What I'm going to share could you go on to the next slide, please? Thank you. So I'm from the Child Health and Development Institute, and we are an independent nonprofit that's really focused on improving children's behavioral health for all kids in Connecticut. And we do that by working with state agencies, providers, schools, family advocates, academic partners, and others who are interested in children's behavioral health to identify solutions and strategies for improvements in the system. What I'm going to talk about today is outpatient care. I'm going to share some data with you about outpatient services, and this comes through our role working with the state to provide quality assurance for a piece of the outpatient service network in Connecticut. So what are outpatient services? Outpatient is really the kind of the default and the backbone of the children's mental health system. If you look at this visual, outpatient on the left is kind of the least intensive type of mental health services. Typically consists of 45, 50 minutes of therapy every week or two. It is the service that's most frequently used. It's a service that is most widely available. And it's generally where people start when they get mental health services or seek mental health services. And it also tends to be the default when other services are not available that children and families might need. Outpatient is generally offered in the clinic or in the office. There's still some telehealth services going on, and some outpatient services could be offered in schools or even in the home. But by and large, they're offered in the outpatient clinics. The last thing I want to say before I share some data with you is that we don't really know exactly how many outpatient providers there are, and we know very little about the services that cumulatively they provide in the state. I'm going to show you some data about a small subset of them, about 24 of the outpatient clinics. But I think it's important to keep in mind that this is just a small piece of outpatient services, and we don't know anything about, or very little about the rest, about how many kids they're serving, who they're serving, and what their outcomes are for children served. So you can go to the next slide. First piece of data I want to share is these yellow dots are the 22 outpatient clinics. And these are clinics that we have data because they receive some state grant funding that comes through DCF. And part of the grant funding requires them to enter data. So that's why we have this data at all. Those yellow dots are the clinics, and then there's a map of which communities, which towns in Connecticut have children who've been seen at those clinics. You can see virtually all the towns in Connecticut have children served, some more than others. These clinics tend to be larger clinics and are frequently in the larger urban areas, but not all of them are in the urban areas. So they do serve kids from all over the state. Can you advance once to the next? In the last fiscal year, they served more than 27,000 children for outpatient mental health services. See that trend is increasing since the pandemic. And these clinics, by and large, serve children who are somewhat aligned with the state demographic population, but are slightly more likely to serve children who are Latinx or Black than the state population. So they are generally serving that population. And again, it depends where the clinics are, and you'll hear from some of the providers today about their more detail about their settings. Outpatient, the kids who receive mental health services at these outpatient clinics have averaged about 20 treatment sessions. Slightly more than half of them significantly improve. And national research kind of shows that only about half of kids that get mental health treatment show significant improvements. So that's slightly better than average. About half of the kids who get mental health treatment receive an EBT, and here's one of those acronyms which I'll spell out. It's an evidence-based treatment, and I'm going to talk a little bit more about those in the next slide. The last thing I just want to highlight from the previous slide is that the clinicians in these outpatient clinics often have a caseload of 60 to 80 children. And if you think about, an hour a week of therapy, there's no way they're seeing 60 or 80 kids a week. And more often the treatment frequency ends up being about every other week. And that's in part due to, the requirements for caseloads is built on the reimbursement rate and the model. And so they have to have these large caseloads who they have to schedule, pretty much back to back many days in order to hit a certain number of treatment sessions per week. Okay, you can go to the next slide. I just want to say a couple things about evidence-based treatments. I said almost half of kids in these clinics, and again, just in these clinics, have received evidence-based treatments. And there are a couple of specific treatments that the state has supported and continues to support for children that treat anxiety, depression, conduct, and trauma or traumatic stress. Couple of things that I think are important to keep in mind is that, I mentioned about half of kids show improvement overall. And you can see in the bottom right, kids who don't receive an EBT show some modest improvements. But the kids who do receive one of those two evidence-based treatments show about twice the rate of improvement as other kids who get more general outpatient treatment. And then the other thing I want to note here is that, there's a lot of research showing that there are disparities for children of color in mental health service access and in outcomes. And you can see here for kids that don't get an EBT, there is a disparity there where white children do a little bit better. But when children do get an evidence-based treatment, those disparities are reduced or even reversed. Okay, you can go to the next slide. There is an economic reason to consider evidence-based treatments in addition to the reason, in addition to the idea that they help kids get better quicker. And the economic data here is from the Washington State Institute for Public Policy, where they calculate the estimated savings to society and to the individuals receiving services. And just, based on the numbers in Connecticut for 14,000 kids who've gotten an EBT, this is the estimated costs over the last 12 to 15 years. You can go to the next slide. I think this is probably my most important slide, because I think it really gets to the heart of the problem. We have a dedicated network of outpatient providers. The clinicians that do this are really in it to help families. And through the pandemic, people worked really hard to see families virtually, to make adaptations and to continue to help families. But the reimbursement rate for, in this case, for the 45-minute outpatient therapy session has not come close to keeping pace, even with inflation over the last 10 or 11 years. And so this puts increasing pressure on the clinicians, on the agencies who can't reimburse the clinicians. And then they get into that cycle where they need to bill more sessions in order to hit productivity targets. And then the staff feel that pinch of having to see more and more clients without enough, without a reimbursement rate that can adequately support their service delivery and even high quality service delivery. So I think that's my last slide. I'll turn things over to the next speaker.
Okay. Back to me. A little bit about LifeBridge Community Services. We've been serving the greater Bridgeport region for over 170 years. The past 20 plus years, we've been providing behavioral health services. We serve adults, children, and adolescents. And we are also licensed as an outpatient to provide outpatient substance use treatment as well. We have offices in both Bridgeport and Fairfield, but we do serve all towns within the greater Bridgeport region. Last year, we served roughly 1,500 clients, of which 16% were children ages 6 to 18. However, over the next 5 years, we expect to increase the number of youth served by 134%, more than doubling the number of youth served, while further strengthening our expertise in treating trauma. Just a little bit of information on how we're going to expand. We receive funding from the Department of Public Health, a health disparities and prevention grant that enables us to renovate unutilized space in our building in Bridgeport. So once the renovation is complete, we'll be able to hire 7 additional clinicians so that we can open our doors wider to serve more people. And we're grateful for that. In terms of our client demographic, we serve minority and low-income clients primarily. The vast majority of our clients, 68%, are Black, Hispanic, or Latino, and 84% utilize Medicaid coverage. We do offer a discounted sliding fee, and nobody is turned away due to inability to pay. In terms of our services, in addition to providing individual and family therapy, LifeBridge is for the first time incorporating clinical art therapy, which is a treatment modality that is well suited for youth. Art therapy is especially beneficial for survivors of prolonged or recurrent trauma. Art therapy, because this is an engaging therapy for children and adults, they're more likely to continue to participate in treatment until their condition improves. LifeBridge is now providing group therapy for youth. We just launched these after receiving feedback. Group therapy provides the therapist with the opportunity to see teenagers in a more social setting and some of the social problems like bullying, social anxieties, etc. We also started a parent support group after a discussion that I had with a parent who had just shared with me the challenges of raising a child in this generation, both with technology, bullying, school shootings, you name it. It's challenging for parents. So we launched these parent support groups, just recognizing that as the nation grapples with the youth mental health crisis, parents are suffering too, as Charlotte had just mentioned. If we really want to understand what's going on with youth, we have to understand them in the context of their families. And one crucial way we can support youth is by supporting their parents. I once heard Commissioner Durantes state, and I'm going to quote her, "We can keep doing things the same way and continue to get the same results, or we can advance our practice to better address the needs within the community." And I mention that because that really is a philosophy that LifeBridge seeks to live by. So in 2019, we were one of 8 sites in the state to receive designation as an outpatient urban trauma center through DCF. And as a member of the Urban Trauma Provider Network, our clinicians are receiving training to recognize and treat racial trauma and other forms of urban trauma. Next slide, please. Oh, you're there. You beat me. Many Bridgeport children grow up facing significant challenges, such as living in poverty, attending underperforming schools, experiencing trauma, or living in fragile home situations, all of which are risk factors to their mental health. Many people are surprised to hear that well-being disparities in Fairfield County remain among the greatest in the country. Bridgeport has one of the highest poverty rates in the state, while the average poverty rate across the county is only 2%, compared to 10% in the state and 15% nationwide. Bridgeport's poverty rate is over 10 times as high at 21%, with 1 in 3 children living in poverty. Bridgeport has the lowest median household income in the county at roughly $45,000, compared to much wealthier neighboring towns like Weston and Darien, whose median household income is closer to $200,000. Another contrast between Bridgeport and the rest of the county is its racial demographic. Fairfield County is 59.8% white, while over 80% of Bridgeport's population is non-white. 30% of Bridgeport residents are foreign-born, and 22% of the population age 5 or older are linguistically isolated. Languages other than English are spoken in 48.5% of Bridgeport homes. Bridgeport is known as what is known as a federally designated mental health provider shortage area. It's a designation by the federal government, meaning we do not have enough mental health providers to meet the need. In a 2019 assessment, only 30% of respondents indicated that Bridgeport residents have regular access to mental and behavioral health care. And then last statistic that I'll share with you, statewide, 18.4% of hospital child behavioral health emergency department visits that result in inpatient admission, compared to 43.6% for Bridgeport's St. Vincent's Medical Center. These statistics demonstrate the urgent need for quality trauma-focused treatment services for Bridgeport communities.
Marissa?
Greetings, everyone. I first and foremost would like to thank Charlotte. I too am a parent. I am a lifelong Norwalk resident, and I have 2 children, a 7th and 8th grader. And thank you for your courage, because I can think of nothing more important as a parent than the mental health and well-being of our children. So I just wanted to thank you for sharing your story and that of your daughters. So my name is Marissa Mangone. I am with Mid-Fairfield Community Care Center. As I mentioned, I'm a lifelong Norwalk resident. Mid-Fairfield was established in 1956 as part of the network of outpatient behavioral health clinics funded by DCF in the state of Connecticut. We really serve as a safety net for children and families who are unable to access and or afford private behavioral health services for their children. In Fairfield County, I know Edith provided some statistics before, but private therapy can cost up to $350 a session. At psychiatry, that's significantly more, and many of our families are unable to afford private care. So again, Mid-Fairfield helps all families regardless of their ability to pay. We have 4 sites that are located within walking distance of each other. And we not only serve the Norwalk community, but surrounding towns as well, such as Darien, New Canaan, Westport, Wilton, Weston, and even some families in Stamford. We currently have about 10 different programs. And we are in actually all 21 Norwalk public schools providing a variety of services. Our largest program, which I'm going to briefly touch upon today, is our outpatient children's clinic. Every year within that program, we serve close to 700 children, and that is just in one of our programs. A variety of symptoms include depression, PTSD, anxiety. And I know we'll talk briefly about all of this later. And as Jason explains, about 90% of our clinicians within our outpatient clinic are trained in evidence-based practices as listed here, TFCBT, Alphabet Soup DBT, and we are actually getting some of our clinicians trained in a newer model, specifically around trauma, EMDR. One of the distinguishing factors about Mid-Fairfield is our bilingual capacity. Within our outpatient clinic, we have 15 clinicians, and we have 5 bilingual Spanish-speaking bicultural clinicians. And we also have 2 Haitian Creole-speaking clinicians. And we demand is so significant that we do not have enough capacity to meet the needs in our community. So it is incredibly, incredibly important to be here today to talk about that need and what we're seeing in the community. And I don't know if you can switch to the next slide. So in October 2022, Positive Directions in the Norwalk Partnership and Norwalk Acts conducted a survey of students within Norwalk Public School, using Norwalk Public School because that's where most of our students or most of our youth are. There are other communities such as Darien and New Canaan that also do this survey. You see the statistics here, but one of the things that I want to you to take away is that 254 students surveyed reported that they had attempted suicide within the past year. That is staggering, it is astounding, and as a parent, it is terrifying. Again, Mid-Fairfield, like all of these amazing organizations, are here to meet this need. In addition to the mental health needs, we will also talk about those social determinants of health that so many of our children and families struggle with. Access, housing, language barriers. It is incredible, and being able to have an organization like Mid-Fairfield and so many of these organizations that provide these types of outpatient services are essential. They are critical to support our children and families, and they provide access, again, for those that are unable to access that private treatment and level of care. Know if the next presenter would like to speak.
Jennifer?
Good afternoon, everyone. I'm Jennifer Nadeau. I'm a licensed clinical social worker, and I'm the Senior Vice President of Child and Family Services at Community Health Resources. I'm going to talk a little bit about Community Health Resources and then go into kind of a snapshot of our service area, and then talk about just in general some of the things that the families that are all of our outpatient clinics that are here today are struggling with. So CHR is a leading nonprofit behavioral healthcare provider in Central and Eastern Connecticut. Last year, our outpatient clinics provided services to over 4,000 children and families across the state of Connecticut. We have outpatient settings in Central and Eastern Connecticut, clinic-based settings, but also located within some schools, along with partnerships that we have with primary care physicians to be a preferred referral source for pediatricians to send referrals to us. We offer clinical and psychiatric assessments, crisis intervention, 24-hour on-call emergency services for families. The list of what we provide kind of goes on and on. It's very similar to all of the other outpatient providers that are here today. I think one of the things that I want to highlight around our outpatient services is that many of the services that we provide to our families are actually non-billable services. So what that means is we're unable to submit claims for insurance, or we do not receive funding through the state in order to provide those services to the youth and families that we serve. So for example, if we're providing parent support, oftentimes that is not a billable service. If we're providing case management or collaboration with another provider that is involved with a family that we're working with, we're unable to be reimbursed for that service. And so many of us as providers have needed to get creative around where we seek funding in order to provide that additional support, which is so essential to the families that we're working with. I think that's one of the biggest areas that most of us as outpatient providers would say is really missing from our service system. And I know we're going to talk more about that as we go forward. You could go to the next slide. So in terms of a snapshot of the needs in the CHR service area, so when you compare to census data, the population of our service area is over 1 million people, about 25% who are under the age of 18. More than 65% of the youth in that service area are considered low income, as evidenced by factors including poverty levels, Medicaid eligibility, and free lunch eligibility. At CHR and our outpatient settings, over about 60% of the families that we provide services for are Medicaid eligible. In terms of well-being disparities, we see high rates of exposure to trauma in our service area. So when we looked at data for the youth that we provide services to over the last year, 37% of them have endorsed an exposure to trauma. And that's just of the youth that have actually disclosed it, right? Because we know that oftentimes youth and families don't always disclose that information. I think that data, it really does mirror the data that we find from the National Children's Traumatic Stress Network, or the NCTSN, which shows about 2/3 of all children in the US have experienced a traumatic event by the age of 16. That's astounding. I think that there's also growing concerns around the number of youth and families who report things like vaping and smoking, right? The substance use that we hear about is increasing. We started doing additional screening around vaping behavior and providing education to youth that we see across our outpatient settings. Around 12% of all of our admissions since we started doing that result in a positive screen. And then we find out throughout the course of treatment, oftentimes youth don't necessarily disclose information to us when they first come in. So over the course of treatment, we're finding out more and more that the incidence is actually much higher than that. I think that the legalization of marijuana has also led to changes in beliefs and, families having different perceptions around whether or not something like vaping is actually a bad thing, which we all know that it is, but families have different thought processes around that. So in regards to kind of this next topic, right, changes in child behavioral health needs and access statewide. So this is really looking over the past 3 years. And when you think about what's taken place across our state, across our nation, across the world over the past 3 years, right, there are drastic differences. The pandemic has certainly had a lasting impact on the families and the youth that we serve across our settings. In terms of the needs of families, I think one of the biggest areas that we hear is issues around transportation, right? Being able to get to their treatment sessions is a huge barrier. There's limited transportation options. There are sometimes, avoidance of families participating in treatment due to transportation barriers. We also see, right, that there are issues around equitable access to treatment. Families that are struggling in some of these areas are going to have a more difficult time engaging in treatment with us. When you think about kind of basic needs of a family, if those basic needs around things like housing, making sure that they have food on the table, making sure that their child is able to go to school, right? If they're unable to have those basic needs met, it makes it even more challenging for them to then engage in treatment. That kind of goes into the socioeconomic challenges that we have listed out here around poverty and hunger, community violence and trauma, unemployment, wages and basic needs. And then the other piece to highlight here around the needs of families are around language barriers, right? We know that there's a drastic shortage of not only bilingual clinicians, but also BIPOC staff, right? We want to make sure that the clients that we're serving, that the staff that are providing those services are representative of the background of the families that we're providing services to. And so that is a systemic issue that I'm not sure we're all going to be able to solve very easily, but I'm hopeful that we can all put our heads together to be able to come up with some potential solutions around those areas. When we think about the needs of the children that we're serving, right, certainly some of them kind of echo the needs of the families. But I think one of the biggest things that we're seeing across our outpatient settings is an increase in the acuity of the youth that we're serving. One of the, I think, first slides that Jason shared was around kind of the system of care, the different services, and kind of the acuity or intensity level. Outpatient really is the backbone of our service system. If youth can't get into another level of care, they end up in our outpatient clinics. And so we're often providing a significant amount of support, case management, crisis management to these families in order to just help them maintain until they can get to that higher level of care. I think in regards to other needs, certainly, there are social and emotional issues that the youth are struggling with, right? We've heard a lot about the incidence of suicide. We hear a lot about bullying, the impact of social media and the kind of constant connection to everyone has had a huge impact on the youth and the families that we're serving. And then, of course, there's systemic changes, right? So I think that there are many changes that we've seen really over the past 3 years that have really just increased, the acuity of not just the youth that we're serving, but the families, right? So these kids are coming to us at a high need, and so are the families, the caregivers, and the parents that the children are living with are also in great need of supports. And so not only are we providing support to the child, but we really try to look at the entire family as a whole and what can we do to support the caregivers or the other family members in order to be able to meet the needs of the family to help meet the needs of the child.
Marissa?
Yep. So I think one of the things that Jennifer had just spoken about is, kids coming in and wait lists and the need. And the last thing that any of us as providers want a child or family to do is to have to wait. And there are many challenges that unfortunately have our families wait. And so everything from intake, right? There's so many things that a family needs to do prior to that first appointment. And it's finding a provider, right, that takes insurance, or finding a provider that has availability on their caseloads and their clinical caseloads. There are a lot of calls, initial phone screenings, collecting information, data, scheduling appointments. And many of our providers do not have that capacity to even be able to do that, especially for children and families where language barriers impede access to care. I also want to mention, with regards to intake challenges, there are so many other levels and layers that our staff need to do in order to get that family in. Paperwork, all of these collateral contacts that don't necessarily afford reimbursement. And also families that don't show up due to these transportation barriers or other barriers. We do not get reimbursed for those services as well. So it is incredibly, incredibly challenging. Higher levels of care, high acuity cases, children coming in younger and younger and younger with such significant need that oftentimes may lead to treatment failures because staff are not equipped to meet these needs. Lack of resources for bilingual clinicians and families in the community is so significant. And so when we say resources, it's not just for the treatment, but also those additional services that children and families need above and beyond the clinical spaces. Do you want to slide out, go to the next slide? Oh, I think one of the other things, I don't know if the slide had gotten taken out, but one of the things I did also want to mention is the workforce challenges that so many of our clinics are facing. Such significant workforce challenges. Therapists and clinicians are going to private therapy, private practice, where they can, go ahead, Jason, I think this is your slide too. I think there was some confusion in the slides, but wanted to bring that up as well.
I think my slide was the one right before and the one right after. I'm not sure I don't think this was my slide.
Okay, so then I was looking at, okay. So anyway,
Right.
Nope, no worries. There are also, as I mentioned before, workforce and recruitment issues. Licensed clinicians are very hard to find, and especially bilingual Spanish-speaking, Haitian Creole-speaking clinicians are incredibly hard to find when they can be going out to private practice, providing telehealth. Within the outpatient setting, we believe that face-to-face therapy is incredibly important for our families. And so we require our clinicians to be in person as much as possible. Having to compete with significantly higher salaries in the private sector continues to be a challenge. Again, and all of the additional burdensome challenges that go to providing these types of services. One of the things that we've seen specifically at Mid-Fairfield is through our parent company, Clifford Beers Community Health Partners, really being able to help with the burdensome, taking some of those burdensome activities off of our clinicians, such as billing, such as sharing of resources that allows us to be able to help support these children and families quicker. So in addition, there are so many requirements that our clinicians need to do for regulation purposes, our licensing requirements, and again, lack of funding. We In addition to DCF funding, federal funding, we also significantly rely on the private philanthropy within our communities to be able to sustain our services, because our service delivery costs are significantly higher than that of the reimbursement rates that we are getting from Medicaid and private insurance. And then for those families that don't have insurance at all, we do provide that sliding scale. So there are significant challenges and financial barriers for all of our clinics. And so, yeah.
Jason?
Right, thank you. So I'm just going to summarize some of the system challenges and needs. And I think, you know, in going through this, it's important to keep in mind, you know, these are the system needs that I think will address many of the concerns raised by families. So when, you know, when Charlotte talks about wait lists and difficulty, you know, getting support with school, and you heard some of the other speakers talk about, you know, the outpatient clinics do all of this extra work, including case management and support of families that isn't reimbursed through the current model. These system challenges and needs, I think, are really really emphasize the first one, which is the funding of services and how we fund and reimburse outpatient services. So I showed you the graph of just the inflation difference over the last 10 or 11 years. And I think it's similar in terms of grant funding, that grants have been relatively flat funded. So the clinics are really trying to serve, you know, a more acute population, children and families with more needs, more children and families with you know, 25% fewer dollars through Medicaid reimbursement over the last decade. The second point on reimbursement is the private insurance limitations are really growing the disparity in access to care, because the insurance reimbursement rates and limitations are pushing only the families that can afford to pay out of pocket to the many outpatient therapists, and then the families that can't afford to pay go to, you know, the clinics like you heard from today, that don't turn families away, and so they're increasingly getting more of those families who have less ability to pay. The second main challenge, I think, is about the lack of data. And again, you know, we really know very, very little about the broad network of outpatient services provided through private practice, through group practices, through other licensed outpatient clinics that are not receiving state grant money. And we don't know, you know, how effective those services are, what's working, who they're serving, and so I think the lack of data is a big one. And then the last, you heard several of the speakers mention the workforce. Workforce is increasingly strained and overwhelmed. It's in part due to the pandemic and the associated increase in children and families with needs. The workforce has their own families, and so, you know, are under stress as well. And again, the current reimbursement model doesn't really allow the time and capacity to provide clinicians with training that they need in specialized populations, like in trauma or young children or autism, developmental disabilities, substance use. And because so many clinicians are booked back to back all week long, trying to see families in order to hit their reimbursement targets. And then the limited Spanish-speaking clinicians and diversity among clinicians is also a longstanding challenge in terms of the workforce. All right, I guess I'll keep going. So to flip those around into policy recommendations, I think, you know, I would boil it down into these three: to adequately fund outpatient services, minimally, you know, look at inflation and make sure that the rates match inflation. But in reality, there are all these other things that outpatient providers do with case management and working with schools, going to an IEP, things that are not really possible or done at a loss in the current model. We also need to strengthen the parity laws for behavioral health. I don't know, my healthcare plan goes up a lot every year, but the reimbursement rate for mental health clinicians doesn't go up. There's many private insurance providers that make accessing behavioral health difficult or cost prohibitive for many families. The second is the data collection standards. We do need to know a little bit more about what providers are doing, who they're seeing, and how their services are effective. And especially if we want to think about how do we improve the system as a whole, and where are the pain points and the areas we need to really look at. It's hard to do that without any data on what's happening. And then last is to look at administrative requirements that may be unnecessary or are duplicative. And many of the providers will talk about all the different licensing and regulation requirements they have for different governing bodies in the state. And it really puts a huge administrative burden on them.
All right, we're at the finish line. Our recommendations for solutions. It should be no surprise to see the recommendation for increased Medicaid reimbursement rates. None of us are surprised by that. I will say this, just to tag on to what Jason just shared, a tangible example of some of the challenges when clinicians are leaving us to go to private practice or to for-profit businesses where their patients there are essentially handpicked. People can turn people away. They often don't take the more severe clients, but they're being paid more. So who wouldn't want to go work there, right? Your clients are easier to work with, and you get paid more money. So it's really unfortunate that the Medicaid reimbursement rate is so low, because ultimately the families suffer. But in terms of getting creative with how, just saying we want more money, what would that look like? So one way to ensure that service providers are serving the most vulnerable and to ensure we're providing the best quality care possible would be to reimburse providers at higher rates when we demonstrate quality. So one recommendation could be to use CMS's case mix index, for example, which some states use, which is a metric that reflects the diversity, complexity, and severity of the patients treated. So treatment for populations who have historically experienced inequity in access, or who have more complex or severe issues should receive a higher reimbursement rate. It just, makes sense. The next one I'll just mention is some schools are able to provide basic counseling services. However, unless the school has a school-based health center with prescribing providers, the child's medication needs can be overlooked. So it's becoming increasingly difficult to find, though, prescribing advanced practice registered nurses or psychiatrists, especially those that's prescribed for children. We're finding that APRNs are expecting upwards of $120 per hour because they realize they're in high demand, and that is way higher than our reimbursement rate. The past 2 years, we've actually lost money at LifeBridge on our medication management service line, and this can't keep happening. We keep providing the service, though, because we know it's essential for families. Currently, it's a regulation in the state of Connecticut for community providers that treat children. We must have a medical director on staff, and the person must be a psychiatrist specifically with experience treating children. Many psychiatrists are now retiring, which will make it even harder to meet this regulation to keep serving kids. We recommend revising this regulation to allow medical doctors or MDs to serve as medical directors instead of requiring the expensive and hard to find psychiatrists. And some states also do that. They allow medical doctors to serve in that role. Currently, Connecticut does not certified community behavioral health centers, or CCBHCs. CCBHCs are becoming increasingly common across the country. They provide a higher standard of client-centered care that's inclusive of case management and care coordination. We recommend that the that we consider providing certification for CCBHCs and provide a higher reimbursement rate for care provided by CCBHCs as an incentive to provide high quality coordinated care. Currently, Medicaid does not reimburse for case management. We've heard that a lot, right? I will just tell you, you heard me say that in Bridgeport, half the population are Spanish speaking. We have one Spanish speaking clinician at LifeBridge. That's how difficult they are to find. And where we see the problem, most of the kids are bilingual. They speak English and Spanish. But how does the provider speak to mom and dad who aren't? So it's a problem that really needs to be addressed. But in terms of case management, right now, a lot of our clinicians, our licensed clinicians, are providing case management services. You know, you could be there for depression, but if you don't have a home and you're living on the street, it's going to be really hard for your depression to improve if the housing issue isn't addressed. And so our clinicians are doing a lot of case management that we're not getting reimbursed for. So the recommendation would be for clinicians to be able to get reimbursed and be able to reimburse us for case management and or enable us to hire case managers so that we don't have to find creative ways to find money to meet this need. It really is a cost burden, but absolutely needed with the populations that we serve.
All right, and we can now open it up for questions.
So thank you very much.
Sorry, let me also interrupt that we have some hands raised on screen too, so I want to be mindful of that.
Yes,
Thank you.
thank you so much. Thank you so much for your presentations. They were revelatory. Really appreciate the information and the duplication in recommendations from two of our speakers. I mean, you could have written each other's slides. So I do have one question for Jason. My question is, when you spoke of services provided in 2023, the OPCC data, it was a third sessions telehealth, and that was in 2023. So I'm curious about the telehealth as growth, what the result is of it. And I know that there's been, I believe in New York City, they just said that telehealth was going to be available to people in schools. And I'm curious how you're all seeing the telehealth happening as providers and what the efficacy of it is as you're looking at 55 to 60% of your clients in this chart improved. How much of that was telehealth, if you know? And I know there's a lot of questions around telehealth for teens, so that's why I'm raising it.
Yeah, I can clarify, yes, it was 1/3 of the sessions in fiscal year 23 in outpatient that were telehealth. I think it might have even been slightly higher in the year before. I think the providers probably can speak better to, how it's working and how it's used. We are just beginning to look at some of the data on, the relationship with outcomes. I don't have anything at this point, but we're hoping to have some info on that soon from the Connecticut OPCCs.
If I may,
Thank you.
we actually brought this up on our planning call that there isn't a lot of data available about the effectiveness of telehealth. And that's a gap, right, in terms of data collection. We pulled data out of our electronic health record, and 42% of youth are currently using video telehealth. Although we do know it's not optimal. Think about how education happened when everything was virtual. We do prefer that the family comes in, but that's not always an option. I will say I missed a bullet on one of my slides as a recommendation. Currently, the families have to come to us or they use telehealth, right? And there's a lot of barriers going from the school is doing a referral. Parents have to work their work schedules. They have to figure out a way to get there. The child's taken out of school. There's just a lot of barriers from point A to point B. And it would be really ideal if outpatient providers could actually go into the school and provide counseling there, whether individual or group, but we're not licensed to do that. And so it's a barrier. So we rely on families coming to us or telehealth. So, just again, to give you some examples of, and I'll also note, many may not realize, but currently the state statute, it did change after COVID, meaning either the clinician or the person receiving services have to be physically in the building, one or the other. Both of them can't be remote to get reimbursed. And so again, in terms of trying to provide flexibility to clinicians, they have to be in the building because most of, it's just necessary for reimbursement. Otherwise, it's complicated.
Thank you for that answer. Anyone else? Yes, Alice.
Yeah, I think just to highlight, there's a couple different benefits, certainly, and I think you did speak to it, of the no-show rate. We had somewhere around 35% no-show rate. And when we moved to telehealth, that absolutely decreased in terms of folks being able to attend the sessions, which I think is just a respectful way of helping our families who really might need to take 2 or 3 buses to be able to get to, to get to their services. So I think that it really needs to be highlighted as an important service. And I just need to say that the restrictions placed on a licensed outpatient clinic are so tight and so sometimes hard that people in private practice who receive Medicaid dollars can actually not even have an office. They could work out of their car going to people's homes, which actually is a great thing to do if you have the therapist coming to your home. But with the licensing and with the regulations of an outpatient clinic, we are restricted to delivering the services within a certain paradigm of in-office or with, a certain amount of time. So the oversight of folks who are receiving Medicaid dollars, it may be less than maybe an enhanced care clinic rate, which is a little bit higher. But the reality is we are much more restricted. And that has happened over the years, right? That has changed. When I first was a clinician at Clifford Beers, if a family wasn't coming for therapy, I'd go to their house with pizza. And, we would sit and talk about what's going on. And I know, Senator Moore, that too, right? That's what you did. But now, because of the administrative restrictions that are in place to be a licensed outpatient clinic, it really prohibits, I think, the kind of care that you really would like to see, for families.
Thank you. Senator Seminara.
Yes, thank you everybody for your presentations. Once again, it was very thorough and eye-opening, really. Quite some of the statistics are astounding to me. I did have a couple of questions. Charlotte and pretty much everyone spoke about waiting lists, and I was curious to Charlotte in particular, but also to everyone. What do you have waiting lists, and what are your wait times like?
I'm happy to go first. We actually currently don't have a waiting list, and it's because we've been working on revising and improving our operations so that when we take people the same day, if they walk in, or minimally try to get them in the next day. And the way we're able to do that is when the clinician has an unkept appointment, we plug in somebody for an intake. And, the clinicians are tired and they aren't always pleased that we do that, but it's our way of addressing the waiting list and, preventing the waiting list.
Yeah.
I can.
So at CHR, we also do not have a wait list for our outpatient level of service. Given that, we really look at it as the backbone of our service system, we don't feel that it's appropriate to keep a wait list for outpatients. So regardless of insurance, their ability to pay, we do not carry a wait list for outpatient. I think the wait list that many of us are referring to are actually more for the higher levels of care that we struggle to get access to for the youth who aren't quite appropriate for outpatient.
And I was just going to add as a provider, we don't either have a wait list. What we'll do is a family will come in and we will assign them a clinician that may not be their consistent clinician going forward. But because we do not want them to, wait however long they need to for consistent treatment, we will do check-ins. We will also refer them to group programs. At Mid-Fairfield, we have a variety of group programs, as well as at individual therapy. So one of the things we've also done is hire a specific intake clinician, which will then freeze up some of our other clinicians to be able to increase their caseloads. So that's another thing that we've done at Mid-Fairfield, to have those specific intake clinicians be able to kind of help that wait list time. But the wait list for higher levels of care are significant.
So when you're talking about higher levels of care, are you saying inpatient, residential, that type of care?
Yes.
When
along with the-
outpatient isn't appropriate and you need a higher level of care?
Yeah, so we're talking about the higher levels of care that you just mentioned, but also our community outreach programs. So programs like ICAPS, MDFT, FFT,
IOP, extended day treatment. Sorry, Jennifer.
Oh, it's fine.
Okay, and then I just had one other question for Jason. Does your facility provide group treatment, or is it all individual?
We actually don't provide any direct service, no treatment services. We're a intermediary that works with the providers and the schools and the state to improve the quality of care, but we don't provide services to families.
Okay, thank you. All right, thank you so much.
So sorry.
Excuse me, Dr.
But I'm sorry, Rep Walker's also been waiting.
I know, Dr.
I just wanted to respond. Can I respond to I'm just responding to your question because we're a different hat now. Now a outpatient medical director hat. For 25 years, we never had a wait list, and now we had a year wait list, then a 6-month wait list. This is for outpatient, and part of the reason is that we don't have a model of doing intake to then hold a patient. We don't think that for us, that's not a model we want to adhere to. So I think it's confusing as committee members. Wait, you're saying you're swamped, but you have no wait list. So I think it's important to clarify that. It goes back to Jason's comment. Is the person getting in? How soon are they getting in? And are they being seen weekly or at least bi-weekly? That's really what determines whether kids are getting served in the state, I think.
Dr. Ponson, can I respond to that? He's right. Getting in for the intake's one thing, but it isn't fair to the family to do the intake and then make them sit for months before they can get in for their first counseling session. So that's really what he's referring to, that is not a best practice model. Again, a lot of it is learning best practices with operations, meaning clinicians will complain about really heavy caseloads. They have 60 clients or whatever. But when you sit down with them, and our clinical supervisors have started doing this and taking a look, they have some people on their caseload that haven't been there for over a year. They should be removed. They should be discharged so that we can get more people in and it doesn't look so heavy to the clinician. And we're able to move people forward to get them in for their sessions quicker.
Terrific. I appreciate all those answers. Thank you very much for clarifying.
Representative Walker.
Thank you, and thank you all for your testimony. And Charlotte, thank you so much for opening up your heart and sharing with us your struggles, because that's the only way we can really find out how people are doing. So thank you so much for doing that. I'm going to ask about first, I thought that outpatient clinics can't have wait lists.
ECCs cannot hold a wait list. Actually, when you're in an enhanced care clinic, the increased rate that you receive is that you have the first session with a certain period of time and the second session with another period of time.
Okay.
But not all outpatient clinics are ECCs.
Okay. So I'm going to go to the Medicaid reimbursement, which is the thing that really is confusing me, because I thought I was told that most of the clinics cannot get Medicaid. So can someone explain to me yes?
Tammy, I'm Tammy's puppet. She'll tell me and then we'll go. And I don't mean to speak for DSS if they're here.
No, no,
Anyone
I
else? No.
just, let me just explain, because
Yeah.
I was told in looking at, some of the, programs that we have for, juvenile or child mental health, a lot of the programming was not Medicaid available.
Yes, that is a truth in terms of the clinic. And I don't mean to speak for any of the other providers, but at Clifford Beers in New Haven, we serve probably well over 6,000 to 7,000 kids a year through multiple different programs. Some are DCF funded, like our care coordination and our in-home services, Child First.
Wait a minute, and when you say DCF fund, that's not Medicaid, that's
Right,
DCF.
exactly.
Okay.
But it is not a unit, a service that can be billed within the waiver that is designed for outpatient clinics in Connecticut. Okay, so that we are under an outpatient waiver, which just allows a certain amount of codes that you can bill. So when you're running your outpatient clinic and you're doing individual, family, or group, you have a certain code and you're able to provide that. But if you're doing an in-home service, or if you're going to school for the PPT, you might be able to bill case management, which is a code, a very small code that is for 15 minutes per, and it's $15. So it's $1 a minute. And you only get a certain amount of those per client. So most services in an outpatient clinic are covered by these codes, but many providers are doing multiple services that are funded through multiple streams of service.
Okay.
National Child Traumatic Stress Network, the CCBHC grant that you're doing, everyone here. So in reality, DSS, the unit of service, I have an example, a unit of service for regular 30 minutes outpatient clinic may cost somewhere around $200. Okay.
Okay.
Because a lot of us have full-time staff who need benefits and health benefits and vacation and all of that.
So before you go any further.
Yeah.
Could you guys speak up into the mic, please? We're not hearing you well.
Sorry, Derek.
I'm kissing the mic. Okay. Sorry, I forgot we're on CNTN, sorry. But so what I'm trying to find out is you're getting paid, but it's not through Medicaid. So therefore, the state is not getting Medicaid reimbursement for the services, but the state is still paying you, but it is at a lower wage rate. Is all of that factual?
No.
Okay.
I think maybe let's just stick with outpatient as a describer right now, if that's okay.
Okay.
Any provider who registers with Medicaid and is approved, what's it called, CMAP, through the CMAP system,
okay.
they can receive Medicaid
Reimbursement?
So if you're a licensed clinician, or if you're working under a licensed clinician in a private practice or an outpatient setting, you can receive Medicaid reimbursement. The reimbursement differs by site, meaning if you're an enhanced care clinic, you're average somewhere around $20 more per unit of service than you would if you're not an enhanced care clinic. Okay.
Okay.
And so that unit of service may be, the unit may cost $200, right? Which is benefits and the hourly rate for a clinician to be able to receive, to do the service. Medicaid reimburses perhaps somewhere around $93, $95. And then some of us receive a DCF, 24 of us, a DCF outpatient grant that over the years has remained flat, maybe gone up a little bit in terms of percentage, but the numbers of kids we've served has increased and increased. So it averages probably around $20 per unit of service.
Okay.
So the reimbursement from DCF and DSS may come to somewhere around $140, $130. And so for every unit of service, we lose about $60.
Okay. If I would just ask the
Yes.
committee that if we could get a little bit more into the weeds of this, because I think that this is going to be critical for us as we talk about expansion, that we understand what the reimbursements are and everything. So thank you, Madam Chair, and thank you, Mr. Chair. Thank you.
Can I just make a follow-up statement to what Dr. Forrester stated, just so that there's no confusion about, because we keep talking about case management services aren't reimbursed. There are
Please
some
speak up.
clinics that do get reimbursed. It's a very small amount, but do get reimbursed. But I've been told that that was years ago when they designated enhanced care clinics, and that ship has sailed. And so the majority of us do not get reimbursed for case management. I just wanted to provide that clarification.
Okay, thank you. The next person is Jeannie Milstein.
Thank you very much. Thank you, Charlotte, for your courage. You made me think about something when you talked about the schools, and then your daughter's now getting therapy through, the community. Is information sharing a barrier? Dr. Forrester made me think of this too, but some of the restrictions on outpatient clinics. But, I know with HIPAA and everything, I mean, it's, one of the most important things is some kind of care coordination and having sort of seamless transitions between schools and community. Is that an issue?
Yes, it's an issue. I think one of the first things that we do when a family comes in for services is ask what school their child is going to, who their primary care physician is, who are other providers that the family is working with, so we can obtain an ROI, a release of information, in order to be able to share information back and forth between those other providers, between the school system and ourselves. But I think, one of the challenges that we keep going back to is our clinicians are carrying caseloads sometimes upwards of 80 to 100 clients. And so the ability for them to be able to do that case management themselves and the care coordination is just overwhelming. When you think about having 80 children that you're working with, to have to call every single one of their schools, every one of their primary care physicians, and have that ongoing collaboration, it's not that they don't try to, it's very challenging. And our providers are working into the evening, and oftentimes if they have a no-show or cancellation, that's when they're trying to make some of these kind of collateral contacts, but other providers are not necessarily working those same hours. Oftentimes, schools, and our teachers, right, they're great. They do so many amazing things, but the school staff stop working between 3 and 4 o'clock. And so there are additional barriers and challenges for us to be able to connect across the system.
Senator Austin also had her hand up.
Yes, thank you. Senator Lesser.
Thank you. Just following up on Representative Walker's question, just about Medicaid reimbursement rates. We currently have a Medicaid rate study, and I was wondering if anybody on the committee knows if this particular part is covered by the rate study, and that's really a question for Mr. Galtieri. But if there's other folks who know, they can certainly weigh in. And sort of following up on that, if we would need to update, if we were to make changes to reimbursement, do we have to update the waiver? What would be the mechanism for us to consider something like that? Thank you, Senator Lesser. As some people here on this council are probably familiar with, last year as part of the budget, there was a methodical process that was instituted as part of the budget implementer that will look at a two-part strategy for looking at rate sufficiency across Medicaid. Phase 1 of that is prescribed by statute to look at behavioral health, dental, and primary care physician rates. Then there'll be a subsequent follow-up phase 2. So DSS is in the process of procuring some initial findings. Our hope is that we'll have at least some actionable information going into the budget correction year in February for those first few service types. Great, thank you. And does anybody know about the procedurally, if we would have to update the waiver? If not, that's okay. I'm just curious. The answer is no. Okay. No, people don't know. Nobody's raising their hand. That's all. I didn't. Yeah. The answer is yes. Representative Walker thinks it's yes. She would know.
I think the waivers can be updated very well, actually. I have to kiss my, I'm sorry. I think that the current outpatient spa waiver that is in place is not sufficient. And I know that DSS has just rolled out the waiver, the 1115A waiver for the SUD population. I know that there has been 1115A across the state would allow for a lot of the services that LifeBridge and other folks were talking about, because it allows for mentoring, in-home services. It really expands it. The worry would be what the rates would be and if we would be able to afford it. The Integrated Care for Kids project that Clifford Beers is running as a pilot for CMMI right now. We just passed the state DSS and DCF. We just worked on a rate, an alternative payment methodology for care coordination. And that is targeted case management that actually we're piloting in 2 zip codes in New Haven. And we're hoping to see that be able to transfer across the state, which then would allow for in-home care coordination, addressing social determinants, physical and mental health services in the home.
I believe that Ms. Gio is next. Excuse me?
Senator Austin.
Oh, Senator Austin, I didn't see your hand. Apologies. You did it online. Oh my gosh. Well, you are the only one, Senator. Okay. All right. Well, clearly you are on top of things. So please go ahead.
So I have 2 questions. One relative to where we stand. There was a little bit of a touch on it with a couple of people before that, but have we looked at the partial hospital, the PHPs that are out there, if there are any left, partial hospitals and day clinicals that are for young people, so that you can weave. Sometimes you need to move up, sometimes you need to move down, but if there is no ability to move within the system, are we able to deal with the issues? So I'd like to understand that component of it too, because I think that that's critical, in particular for someone in crisis. And if they really are in crisis, then we need to have the ability for that more intensive treatment. And I have not heard that yet in any of the systems that we've talked about. And then my second question would be about transportation. And we talked a little bit about that too. And I think that there are areas where we have clear deserts for services, and transportation, when you have no public transportation, is virtually impossible. So many of our rural areas, both in the northwestern corner where Senator Mara lives and in the eastern part of the state, there are no transportation services available. And we seem to be cutting more and more public transportation instead of expanding public transportation. So I'd like to have a little bit of understanding on the areas that, we're experiencing these more dedicated transportation deserts, so that we can explore that too. So thank you. And if anybody wants to comment, any of the presenters want to comment on either one of those, appreciate it.
I'm happy to talk. I don't know if anyone else raised, any of the other presenters in person raised their hand. not, I'm happy to speak about the higher levels of care.
Go ahead.
Okay.
I'm not going to be the one directing you though, but I'll just say yes on this one.
Okay.
And I'm not following the rules anymore.
At Mid-Fairfield, in addition to our outpatient children's clinic, which is the focus of today's primary focus of today's presentation, we also have an extended day treatment program and an intensive outpatient program. So the extended day treatment program is specifically for children ages 5 to 12 with significantly high levels of acuity that need significantly more help than your 45-minute weekly sessions. These children come to us every day, 5 days a week, from 3 to 6. Speaking of transportation, we pick the children up at school, and then they come back to Mid-Fairfield, and then parents, if they're able to, pick them up at home and or provide transportation is provided. These extended day treatment programs are very robust in terms of the types of services and very intensive within the terms of the types of services that these children receive. It is individual therapy, it is group therapy, it is social skills work, it is homework help. It's really this group milieu and this comprehensive wraparound care. And I'm bringing this up because children within our outpatient clinic that do need higher levels of care are able to transition into an extended day treatment program, and vice versa. When a child completes extended day treatment program, they're able to then transition to a lower level of care at Mid-Fairfield. The challenge is that our extended day treatment program is the only one in our region, right? So many extended day treatment programs have closed over the years. Very limited intensive outpatient programs. So in terms of those higher levels of care and those transitions, it is very, very hard to find that level of care within the communities in which we work and are. But I can tell you at Mid-Fairfield, there is that transition again, and that's being able to provide that continuum and that wraparound care across the lifespan of a child. To provide those transitions is incredibly important for organizations.
And you cover only 6 to 12. So do you have a program equally as responsive from 13 to 21?
Yep. About 3 years ago at the height of pandemic, we were getting referral after referral for that intensive, for that spot, right? That 13 to 16. And so we decided that it was incredibly important to replicate the extended day treatment model and really create an intensive outpatient program for our community as well, for those children of that age range. Again, that's 3 days a week, between 3 and 5 days a week. Those kids usually come from around 12 to 3, and then our extended day treatment program is for after school. And we work incredibly closely with the school district to support these kids as well.
Thank you. I think there was somebody else that wanted to.
I was just going to add that for the IOP down in the New Haven area, 5 to 12, the wait list was for about 9 months for outpatient care because we were only taking from inpatient and the emergency room. And of course, someone comes on our wait list because we have to prioritize acuity essentially. And the way to do that is to say, well, they're in the emergency room, they've been boarding 3 days, they've been on the inpatient unit stuck 2 weeks. And so the kids coming from outpatient referrals that need higher level of care that you spoke about, you have to keep them longer on your caseload while they end up in the emergency room, and then they ended up with us. So it was about a 9-month, we could get them in from inpatient and emergency room, but it was really, really difficult to get them in from outpatient. Those numbers have gone down in terms of, that's a lot better now, I think, but that certainly continues to be an issue in terms of availability, accessibility, depending on parts of the state.
Mostly I was concerned about this because I had noticed a lot of the PHP programs that were in Eastern Connecticut had closed down, and the day clinical programs had closed down.
Workforce shortage can be a real issue in this area. One of our programs in Bridgeport was on hiatus for children for months because of a workforce shortage issue.
Thank you. Thank you, Madam Chair.
Okay, thank you, Senator. One last question because we are rounding up to 4 o'clock, but you have been so patient. So thank you so much. Please go ahead.
Thank you. For those who don't know me, I'm Christina Guillo. I'm the Associate Child Advocate, the designee for today for the Child Advocate. I just want to circle back to the wait list question to just get a little bit more clarification on that. So when the providers say we're not carrying a wait list, does that mean that every family that calls is seen timely for an intake and then consistently on a weekly basis? And if that's not the case, is there any data on how frequently are kids being seen? So if you're not able to see every child on your caseload weekly, are they being seen monthly? Are they being seen every other week? And I think the other question is related to that. Are there families that get turned away because you simply don't have the capacity? And if that's the case, do those numbers exist anywhere? Do we know how many families are referred elsewhere because we don't have capacity and they're actually not getting the service, but they're also not listed on a wait list somewhere?
I can start first if you don't mind. I think this is a data gap too. A lot of from the phone call to intake data gets lost because we really rely on front desk staff, or it's hard to collect it. But I'll say I can speak at LifeBridge. Again, we don't turn anyone away, get them in for the intake, but also place them on a clinician's caseload so that they are seen regularly. We're adamant about that. Hasn't always been the case, but improving the way that we operate and the way that we structure our caseloads, we've been able to do that. I don't know if you all.
So at CHR, we are an enhanced care clinic, which I think was brought up before. So we have access to care standards where anyone who calls, we're going to offer them an appointment if it's a routine case within 2 weeks. When they come in for their intake, that also means that we have to offer them a follow-up appointment within that same time frame, so within a 2-week period. Whether or not the family accepts the appointment, right, is a completely different story. And often that's due to different barriers and things that they have going on for them around whether or not they can actually get to the treatment session within that time frame. But generally, we don't feel that in terms of treatment, we want to see our families at least on a biweekly basis, if not more often, because we know that kids who are more consistently engaged in treatment are going to have better outcomes.
Okay, thank you all so much. I very much appreciate the time that you've given, that you've stayed for the extended amount of time. I'm really heartened by the fact that online, almost everyone stayed with us right to the end. So that means that we're all engaged and interested and want to work towards a solution. I was going to comment on some of the comments that were made, but that we've already turned off the screen, so I can't do that. However, excuse me. However, what we see from today is that the need is great. Even if there's not a wait list per se, the need is great. Reimbursement is an enormous issue. Lack of provision in certain of our areas is a really big issue, and transportation. There's so many things we have yet to dig into. And one of the things I just want to reiterate the point that Claudio made initially, which is we're going to be looking at the finances. The finances are key to every aspect of the work that we're doing. So thank you all, and I look forward to working with you again next month and in the interim.